Hello, my name is Charles James. Today we're here to talk about Advanced RHC Billing. As you can see from the window behind me, I'm in my basement, which makes this the COVID-19 edition. Today's date is September 22nd, 2020. My name is Charles James. I'm President and CEO of North American Healthcare Management Services. We're located in St. Louis, Missouri. We've been in operation since 1992. We provide revenue cycle management, cost reporting, financial consulting, impact analyses, and program implementation for rural health clinics and FQHCs from Oregon to Florida. So today's topic is Advanced Rural Health Clinic Billing. For Advanced RHC Billing, we're going to begin with a brief review. We're going to talk about Incident 2 services, reporting services, qualifying visits. I'm going to do a brief review of multiple encounters and various circumstances on how we bill those. We'll look at care management services, transitional care management, telehealth originating site services, and then we will distinguish that with telehealth during our public emergency. An important section will be commingling and RHCs. Commingling is a difficult, misunderstood topic that creates a lot of anxiety and compliance risk if not done correctly. We will finish with a section on Illinois, Kentucky, and Indiana Medicaid agencies. So let's dig deeper in rural health clinic services. How do we bill multiple visits? What about specialists? Commingling, telehealth services, Medicaid plans, and finally our MCOs. Do they pay our RHC encounter rates? We see in basic rural health clinic billing what goes on this claim form. We already know our qualifying visits are going to go on the claim form. We're going to report one service line per encounter or visit that has a revenue code 052X. And our qualifying visit from the RHC qualifying visit list. The link can be seen at the bottom of the slide. Payment and applicable coinsurance and or deductible amounts will be based on the qualifying visit line. To extend the conversation and answer in detail what goes on the UB04 claim form, here's our answer. Rural health clinic services, physician services, service and supplies incident to the physician services, nurse practitioner, PA, certified nurse midwife services, anything incident to those same providers. Clinical psychologist or CP, CSW or licensed clinical social worker, as described in section 150 of our Rural Health Clinic Policy Manual. Services and supplies incident to our clinical psychologist and LCSW, we see a trend. Visiting nurse services for patients confined to their home, as described in section 190. Keep in mind we have an exemption for visiting nurse services during our COVID waiver. We will not discuss that today, but we will look at virtual communication services as described in section 240 and talk about how those are affected during the COVID emergency. We know from our Rural Health Clinic beginning series that rural health clinic services include certain preventive services. The preventive services each have a little different treatment with how they get billed. We know that flu and pneumo get billed on our cost report, and we don't ever file a claim for those. However, hepatitis B immunizations cannot be filed on the cost report, and those are incident to. Welcome to Medicare is our IPPE, our initial preventive physical exam. Welcome to Medicare visit, eligible once per patient lifetime at their initial Medicare eligibility. But we know that that is a same-day bill and that we can bill that in conjunction with another encounter, and we'll get a separate reimbursement for that. Our annual wellness visits, we know, are standalone services, as are the balance of the Medicare covered preventive screenings are standalone visits, and those get a little different treatment. and we'll cover those extensively in the preventive section of the series. Our preventive services or our sick visits, we determine what the qualifying visit line is by whatever service received the majority of the care, or if that was their reason for the visit, their chief complaint. We have to have, as we established, one qualifying visit from the qualifying visit list, and payment and applicable co-insurance will be based on that qualifying visit line. And again, whichever of the... We know from our beginning course series that Incident 2 services require direct physician, direct provider supervision of the person performing that service, except for care management services. So the provider in our case, or physician, nurse practitioner, who is ordering a particular injection, must be in the building when that injection is given. They have to be directly supervising that person, which again, as we established in the other course series, is the provider does not have to be in the room, but they have to be in the clinic. Except for care management services, those are about the only thing we get under general supervision in our rural health clinic. The effect of our Incident 2 services is an increase in our charge amount in the rural health clinic, and therefore an increase in the patient responsibility. Medicare doesn't change the amount that they pay. An increase in the charge only affects the patient, and the basis of the 20% of that charge will be their coinsurance. Medicare does not adjudicate claims based on our total charge or 0001 line. Medicare adjudicates our claims based on that qualifying visit line. The qualifying visit line must be the sum of all RHC charges minus preventive services. Total charges will be reported as the allowed charges on remits, but the coinsurance and deductible amounts will ultimately be based on that qualifying visit line. It gets confusing when we get remits back because that total charge line does show up, but it's not relevant for anything other than what got submitted on the claim. So here's an example of billing with a CG modifier. Just have one line item on this claim. An established patient was seen for 99213. I use $100 throughout my claim examples, and our coinsurance and deductible is calculated using that $100, and of course the patient's going to have a $20 coinsurance on this charge, and we see that it's a pretty straightforward claim. Our CG modifier gets appended to the office visit, and not a lot of extraneous detail. To report Incident 2 services on our claim, we have a couple different ways we can do this. To demonstrate, we have a Toradol injection and an administration for $20 and $30. We bundle those amounts up into our qualifying visit line. In method number 1, we also have an extra $20 and $30, or $50 total, that we're reporting on the service detail lines that amounts to really excess or false duplicate revenue, because we've reported it twice, once in the detail line and once in the qualifying visit line. Our total charges come out to $200, which will show up on the remittance advice, but all of our patient balances and patient responsibility amounts will be based on the qualifying visit line. So we can use this method. It's easy, it's fine. Both of these methods are correct, but on this one, we're billers. I don't like extra AR built into what we're doing. So our preference is our alternate method. And many sites choose this method. Again, both of these are correct. It's just what works best for you. On the alternate method, instead of reporting the service detail lines and having duplicate revenue built into the total charge, we can report that detail as a 1 cent dollar amount. Anything greater than 0, we can report on the detail line. We bundle the amounts up that we did before. So we have the $50 for the Toradol and the administration. And technically we should bundle the 2 cents up in this, but I don't think it matters if we don't. And regardless, now we don't have increased or duplicate revenue. So both of these methods are correct. Neither is incorrect. It really, again, is which one works best for your organization. Let's talk about multiple encounters. Multiple encounters are allowed when the patient, subsequent to the first illness or injury, subsequent to the first visit, suffers an additional illness or injury that requires diagnosis and treatment on the same day. So we just say subsequent illness or injury, and that gives us 2 visits, right? If the patient has a medical visit and a behavioral health visit on the same day, we also have 2 visits. Again, additionally, when the patient has a welcome to Medicare or IPPE visit and a separate medical visit and a behavioral health visit on the same day, we have 3 visits there, right? One would think that we could get 4 visits if we have a subsequent illness or injury, a sick visit, subsequent illness or injury, behavioral health visit, welcome to Medicare. We could technically have 4. I think that would be difficult to get paid, so those aren't going to happen very often. But a subsequent illness or injury happens it's a fairly common occurrence. Of course, our sick visit and behavioral health visit on the same day is pretty standard fare. So 2 encounters, add in a welcome to Medicare visit, we can bill that by itself too, but these are the situations where multiple encounters are allowed. We report multiple encounters by using modifiers 59 and 25. Modifier 59 indicates a separate condition on the same day are being treated. This is only used for subsequent illness or injury on the same day as another visit. Modifier 25 for us in an RHC is interchangeable with modifier 59. Both of these indicate 2 different encounters, and we do not use modifier 25 in a rural health clinic to distinguish the evaluation and management service from a procedure. For us in the rural health clinic, a 25 modifier is interchangeable with 59 and means a subsequent illness or injury on the same day. So, on the CG modifier FAQ, we have a couple questions about the subsequent illness or injury. Is the CG reported on the subsequent visit, which occurs on the same day as an earlier visit? No. Should we report CG and modifier 25 and 59 together on the same visit for the subsequent visit? No. So let's get that. We don't report CG modifier on the subsequent line item, and we don't report CG and 25 together or CG and 59 together. We only report modifier 25 or 59 on the line that represents the subsequent visit. So here's what that claim would look like. I go ahead and use the alternate billing method throughout the rest of the session. Modifier 59, we see our first line here gets a CG modifier. Our laceration repair patient comes in with a cut later in the day. We're going to report that with modifier 59. In our instance, the laceration repair was $250, so we have a total claim for $350. And again, look, we don't report CG on both line items, and we don't report CG with 25 or 59. Our sick visit and our behavioral health visit are one of the instances where we're going to report CG modifier on the same claim twice. So we're going to report the CG on the sick visit, we're going to report the CG on the 0900 behavioral health visit. Both of these will be paid as encounters, and co-insurance apply as we would expect. Take note, this is a limited number of scenarios, again, that we're going to report 2 CG modifiers on the same claim. We can report 2 CG modifiers with a welcome to Medicare visit and an office visit. Ultimately, that CG modifier is optional for the welcome to Medicare visit. For muscle memory, our suggestion is go ahead and report it, just to be, again, consistent. It's less confusing. But this would be the second instance where, of course, you could report the CG modifier twice on one claim. We have a transitional care management. This does not get a CG modifier. These are paid as encounters, and this is a $150 service. So, pre-COVID, or if we decide to bill a telehealth originating site claim, and remember, the originating site is where originally the patient had to be at one of a qualified originating site in order to have a telehealth service. The remote provider would get the E&M code, and the originating site, or the remote or the distant site is the other term, and the originating site gets this Q3014 for $23. We still can bill an originating site, and most of the time, of course, we can't bill an originating site if we're taking advantage of the distant site billing from the rural health clinic during the COVID emergency. General care management services. We have our RHC specific G0511. This is one of our aggregate codes. The care management service payment for rural health clinics is the average of 99490, 99487, 99484, which the fee-for-service world gets. We do not. That average of those payments comes out in 2020 to $66.77, and that rate gets updated annually as the fee schedule gets updated. But our G0511 gets billed without the CG modifier. We have 2 options for G0511. We have option A, which is our multiple chronic conditions expected to last at least 12 months until the death of the patient, and expected to place the patient at significant risk of decline, death, exacerbation, decompensation. We also have the often overlooked option B, which is any behavioral health or psychiatric condition being treated by the RHC or FQHC practitioner, including substance abuse disorders, that in the clinical judgment of the RHC or FQHC practitioner warrants behavioral health intervention. Option A, 2 or more chronic conditions expected to last 12 or more months. Now, interestingly, we also are going to have a principal care management option, which will mean that if the patient has 1 chronic condition, we're going to get the ability to bill that. It will look a lot like this. But also option B, any psychiatric or behavioral health disorder which warrants behavioral health intervention. The next care management service, which often gets overlooked, is G0512. It is also a RHC specific code. It's the Psychiatric Coordination of Care Management. G0512 is billed alone or with another encounter, just like our G0511. We can only bill this once per month. We have the same stipulation that only 1 provider can do this per month for that patient. Otherwise, the care management service is not available to other providers. The payment rate is set, as we saw on the G0511, at the national average of, in this case, 2 codes, 99492 and 99493. Psychiatric Coordination of Care Management payment for 2020 is $141.83. Now, the G0511 is 20 minutes per beneficiary per month of coordinated care management services. The Psychiatric Coordination of Care Management service is 70 minutes in month number 1 and 60 minutes in subsequent months. And there are a couple of extra service provisions that are required for the Psychiatric Coordination of Care G0512. to try not to be confusing, that is differentiated from G0511, which is still 20 minutes, and any psychiatric condition warranting behavioral health intervention. On the G0512, we actually have to have a care management team in place. So there are a couple other requirements for the psychiatric coordination care management service, but to date I know of no one that has taken advantage of this particular service. So hopefully that's something that we can broaden as people gain a better understanding of its availability. Here are the claim examples for care management services. You can see this can be billed, as we mentioned, by itself or with another encounter. It does not get a it does not get a CG modifier, nor do care management services count towards our productivity standards. So these are not counted in our visits. That's why it doesn't get the CG modifier. In this session, we'll discuss telehealth billing for RHCs. Let's make the distinction of telehealth versus telemedicine. Telehealth is the broad range of services that can be delivered via audiovisual technology. Telemedicine services really refer to the professional services that are rendered via telehealth mechanism. So there's a slight difference in those, and a lot of us use that term interchangeably, but no, a lot of times at the policy level, there is a distinction made between these two slightly different categories. The three types of telehealth services that we have available to us as rural health clinics are virtual check-ins, e-visits, and our telemedicine services. On March 27, 2020, the CARES Act was signed into law. Section 3704 of that act authorizes rural health clinics to be the distant site to furnish distant site telehealth services to Medicare beneficiaries during the COVID public health emergency. Typically, Medicare telehealth services require interactive audio and video telecommunication systems that permit real-time communication between the provider and the patient. When this capability was implemented, we were able to immediately provide distant site telehealth services as an RHC, and it took us a while to get that. I won't go into the whole time frame here, but effective March 27, RHCs and FQHCs were authorized to begin billing as distant site telehealth services. In order for RHCs to bill distant site services and FQHCs, a new HCPCS code was established. G2025 is an RHC, FQHC specific distant site telehealth code for the duration of the public health emergency. It was effective back to January 27, but originating site locations, i.e. the patient's home, was only effective beginning March 6. This is via SE20016. I certainly have a link at the resource section of the slides, but MedLearn Matters SE20016 is what gives us the guidance to bill G2025 and how to do so. The payment for G2025 is another weighted average, just like our care management services and a couple of the other services that we're able to provide. G2025 is going to be paid at $92.03 through 12/31 of 2020, and this is the national average of all of the telehealth services that Medicare allows on the physician fee schedule. So this is a weighted average, just like G0511, just like G0512 in our virtual check-in codes. These changes to the policy were incremental because they were made on an emergency basis. So all of us probably remember the confusion that was out there and the consternation and what are we able to do, what are we not able to do, and really got this guidance in pieces, but it all centers on SE20016. distant site providers, distant site telehealth services can be furnished by any healthcare practitioner working for the RHC or FQHC within their scope of practice. So this is for telehealth services, distant site only. This is not for face-to-face. Any licensed provider. So in Missouri, CMAs get licenses, and RNs certainly have licenses. And I know across many other states, we have these types of healthcare professional licenses. So any healthcare practitioner licensed in their state, RNs, LPNs, MAs, can provide, for example, a 99201, and that would count for a distant site telehealth service. So we're saying a couple different things. Any provider during the PHE can provide a distant site telehealth service as long as they're licensed in that state. We can furnish distant site telehealth services from any location. Remember, the big question was, can our providers work from home and provide telehealth visits to our patients while the patients are at home? And we had a lot of round and rounds about distant site, originating site, what the legislation allows, what it doesn't. Finally, during the PHE, we have the provision that any healthcare practitioner appropriately licensed in the state can furnish distant site telehealth service from any location, including their home, as long as they're working for the RHC or FQHC at the time. So, the telehealth service has to be approved under the physician fee schedule. So anything on that Medicare physician fee schedule telehealth list applies to G2025. So during the public health emergency, that's what we've got. We have to get patient consent to let the patient know that we're going to be seeing them via telehealth, and we need to get their consent to do so. That includes for non-face-to-face services. So here's another general supervision issue. Patient consent can be obtained under general supervision, so the physician or provider does not have to be in the building. So this allows our nursing staff maybe in the clinic, if the provider is at their home working, that allows the practitioner in the clinic, the nursing staff, to get that patient consent under general supervision. So it's probably not an issue we think about always, but patient consent is supposed to be obtained under direct supervision. So big difference for telehealth services during the public health emergency. We can get patient consent under general supervision. Another big change for the public health emergency is that telephone-only visits count. Remember, Medicare really only allows for audio-visual real-time communication for telehealth services, and most of our Medicaid plans, even those that already had defined telehealth encounters, did not allow telephone-only visits. Because so many of our rural patients do not have smartphones and don't have adequate internet access, during the public health emergency, the only way we were going to get our patients seen was to have a telephone-only visit. I put seen in air quotes. Effective March 1, 2020, the telephone-only codes 99441, 442, 443, which are audio only, are allowable to be billed as G2025 services. Remember, we had a lot of back and forth guidance. Prior to SE 20016 and the CARES Act, we had been told telephone-only visits would be virtual check-in. Now we have the ability during the public health emergency that a telephone-only visit is a G2025 distant site encounter, if you will. So there's some confusion over that at the beginning. Virtual check-ins are G0071, and remember, those are not encounters. And telephone-only visits can be distinguished and billed under G2025. Now, the telephone-only visit has to have at least 5 minutes of evaluation and management by a physician or health professional. and we have to report E&M services to an established patient, parent, or guardian. It's a telephone-only service. We can't bill, this is a common definition with our virtual check-in, we cannot bill a telephone-only visit if there has been an encounter from 7 days ago, or if this would cause an encounter, if it necessitates an encounter within 24 hours. So it's really a telephone-only check-in, low-level visit, 5 minutes or more, and we can't have an encounter either side of it. So if we have an encounter either side of it, the telephone-only conversation would be part of that encounter. One of the clarifications we received midway through this process was whether or not annual wellness visits were allowed via telehealth. So Medicare redefined and also released some guidance. This particular quote is from the COVID-19 help desk, that the annual wellness visit may be administered using audio only, i.e. telephone only technology, if a video connection with the patient is not possible. So annual wellness visits can be rendered via telehealth, they can be rendered via telephone only visit, and if the patient can self-report elements of the annual wellness visit, height, weight, blood pressure, etc., we can include those in the medical record to support our level of visit, or the annual wellness visit criteria. So guidance for when the patient cannot self-report and what they can't self-report is currently under review. That which was under review was how to use the CS modifier. So first we got a CS modifier for COVID-related services. So anything relative to COVID, we have to waive the co-insurance and deductible amount. Co-insurance must be waived. We will use the CS modifier to indicate, yes, this patient is in, we are evaluating that patient to see if they need a COVID test. CS modifier gets appended. The CS modifier eliminates co-insurance and deductible for COVID tests, and then what was added to that was, I believe in July 30, don't quote me on that, July, the CS modifier and SE 20016 was modified to include preventive services under the CS modifier first. So CS modifier changed from anything COVID related to anything COVID or preventive visit during via telehealth. So it's a big distinction. We must waive the coinsurance if it is COVID related. And of course, an annual wellness visit would not have coinsurance either. That was the big problem. Without the CS modifier applying to preventive visits, patients were being applied, or claims were being adjudicated with coinsurance amounts, which is incorrect for preventive visits. So telehealth, yes, the coinsurance and deductibles do apply to our telehealth visits unless they are COVID related. So we're going to read on, right? Per SE 20016, we have many CPT codes included in the list of telehealth codes that are preventive visits that have waived cost sharing. So just as we just mentioned, this is the language from SE 20016 that we're going to use the CS modifier to report those services. CS modifier is cost sharing is waived for COVID-19 or any preventive visits furnished via telehealth and FQHCs. Now I know we're being a little repetitive, but there's a major cost sharing distinction we need to make. We've already established that we must waive cost sharing. We must waive coinsurance and deductible for anything COVID related. We may waive cost sharing for telehealth services in general if they're not related to COVID. We may waive those during the PHE, but we're not required to do so. So the coinsurance waiver only applies to COVID-related services, not telehealth services in general. So I think at the beginning there was a confusion about that, but CS waives. We must use CS for COVID-related. We may waive telehealth service coinsurance in general. So it's really a matter that the Office of the Inspector General may waive coinsurance. The Office of Inspector General says that providers may waive coinsurance at their discretion, and they're not going to pursue, they're not going to audit that. So under normal circumstances, we cannot just waive coinsurance. It's important to remember that. We can during the public health emergency, but under normal circumstances, it's not acceptable to waive coinsurance. So, many of these CS modifier claims were paid with the coinsurance and deductible applied. CMS recognized that, and basically the payments, just the coinsurance was mistakenly applied to those. You should not collect those coinsurance amounts. CMS is going to reprocess those claims so that anything with the CS modifier does not have cost sharing. Cost reporting are distant site telehealth services, and those visits will not be used to determine our rural health clinic all-inclusive rate or our FQHC PPS rate. We have to report costs on the cost report, but they basically get reallocated out. So there is a cost reporting impact, but it doesn't affect your rate. So this is how we're going to bill the claims. Remember, prior to June 30, we had to use the CG modifier on distant site services. After June 30, we no longer use. So this is the current billing method for RHC distant site telehealth services. No CG modifier, and CS only if it's COVID related or preventive service or screening. One problem with the G2025 is we're not reporting detail. So just like the annual wellness visit was getting coinsurance applied, since we're not submitting the actual G0438 or whatever the relevant CPT code was, is that G2025 is not providing information to the Medicare Coordination of Benefits as it should. So Medicare doesn't know if an annual wellness visit has been performed or not. And we don't know the coinsurance or deductible amounts that have been applied. So we have some built-in problems with this. The other issue is we have to report that our ACOs and other quality payment organizations, that our FQHC or RHC are meeting our quality measures. And we don't know that unless we're keeping track of the actual detail that's being provided. Now, G2025 does have a work RVU assigned to it, but providers often aren't happy with that. So what if my compensation is RVU based? And now all of a sudden I'm losing a lot of compensation because I've got a set work RVU for my G025. So one of our solutions, and this is a suggestion, you could not submit G2025 claims on them with claim details. So line items will cause your G2025 claims to reject. But many of us are posting our claim. The 95 modifier remains optional. So we're using the 95 modifier so that we can tag all of our telehealth services. It's probably going to be important that we can report on those. We know it will be. Our subsequent annual wellness visit, I put a 95 modifier on here. It's probably important. I think it's important to know, of course, if we're going to post detail in order to suppress that, and that suppressed detail line will not go out on the claim, cannot go out on the claim. And if we don't tag that service detail line with the 95 modifier, we won't know it's a telehealth service, and we have to remove those from our patient visits, else you're going to just destroy your rate. If you post detail, you've got to remove those visits from your visit count, else you will just bomb your rate. So this is the suggested method for capturing the details. Suppress the line item detail, but just submit the 2025. Use 95 modifier so you can keep track of your telehealth visits. And this is what we're using in our shop. So it's a suggested method for keeping track of your detail. Remember, it is a suggestion, not a recommendation. You cannot, if you submit a claim with detail on it, it will reject. So, suggested posting method. Medicare wraparound. So, since distance site services are not paid the all-inclusive rate, Medicare Advantage is not going to apply to these services. So, wraparound, any kind of reconciliation, is not going to apply to Medicare Advantage. So, you're really going to have to check with your Medicare Advantage plan. Typically, if you're being paid the all-inclusive rate, they'll want you to submit using rural health clinic billing rules. If your Medicare Advantage is paying you as a fee-for-service operation, you'll probably just submit according to the physician fee schedule. Let's talk about virtual communication services. There's a lot of confusion over, okay, well, if I can do telephone-only visits, why would I do virtual communication services, G0071? Well, first of all, remember, it's not an encounter. But secondly, let's define what it is. So first we have our at least 5 minutes of communication technology-based remote evaluation services furnished by one of our providers, and the patient has had a billable visit within the previous year. Now the established patient has been waived for virtual communication services. I don't know that it was for the G2025. But virtual communication services, we have the established patient rule waived. We have to have medical discussion, remote evaluation, not related to an encounter within the previous 7 days or within the next 24 hours. Sounds familiar, doesn't it? It's not an encounter. It's 5 minutes of communication technology-based remote evaluation service. And again, so not an encounter. Oops, I've got a duplicate slide on there. We bill that using G0071, either alone or with other encounters. Our payment for the virtual communication service includes G2010, G2012, remote evaluation and management. It does not include remote monitoring, but it also includes our portal visits 99421 through 423. Since we had the portal visits amended, our G0071 for 2020 will be $24.75. We think that will probably go away and those portal visits won't be included after the public health emergency, but we don't know that for sure. Remember, virtual communication service is not just a telephone call, it's an email or a text, or maybe the patient has forwarded a video to you of some kind. Store and forward method, such as a picture or a video to the RHC. And the RHC provider or FQHC provider follows up within 24 hours of having received this patient contact. So we're basically answering questions. Nathan Bow at NARHC said this best. Really answering questions via email and text for our patients, and we can bill for that. So these would be the reasons we would have a virtual communication service, G0071, even when we can bill our telephone-only visits as a telehealth service. So answering questions via email and text is another billable service. So make sure we make use of this appropriately. Got to be initiated by the patient. We have a little flexibility of that during COVID. Can't be cold calling patients, but if there are patients that you know that need to check in, do that. Performed by a physician or other healthcare professional, provided to established patients, which is waived for COVID. Doesn't have an E&M service within previous 7 days or the next 24 hours. We have more than 5 minutes of medical discussion. So Again, still a good benefit to keep in mind. Coinsurance is still 20% of the lesser of the charge amount or the payment amount. So your charge amount should really be the $24.71, and that way the patient, you get what you need, the patient gets their part, and of course consent must be obtained for non-face-to-face services. Our virtual check-in claim example. Virtual check-in encompasses check-in and evaluation, not monitoring. And again, just like our care management services, we can bill this with or without an RHC encounter. And of course, since it's not an encounter, there would be no CG modifier on this HCPCS code. This G0071 is an RHC FQHC only HCPCS code against the national average of physician fee schedule amounts for those services. Portal visits are included in our G0071. Those include all three levels of those. So that's part of our G0071. It was not at the beginning of the public health emergency. Same information. I clearly need to eliminate some duplicate slides here. We can waive cost sharing again, and we can obtain consent verbally by our clinic staff. Commercial insurance all have their own reimbursement mechanisms for telehealth. They most closely follow Medicare fee-for-service, and really you've got to confirm those with your own plans because they especially vary in what codes they want you to bill. So it's really important that you check with those commercial insurance plans that are your major payers to make sure what their requirements are. Commingling and RHCs. Commingling is a difficult topic. It is fraught because many of us listen to this presentation and think, oh my goodness, I've been doing it all wrong. Hopefully that is not your reaction to this presentation, because the whole point is to eliminate the mystery and figure out how to make sure you're doing it right. So let's check that out. Among the topics that we're going to discuss are some basic definitions. What are the considerations for our cost report? We'll start to look at some of the different kinds of commingling, like duplicate reimbursement and financial triage. We'll discuss and differentiate non-rural health clinic hours and carving out non-rural health clinic hours as distinguished from what non-rural health clinic services we can provide and how that's different and not a commingling consideration. A big commingling risk is our patient treatment areas and procedure rooms, and how do we integrate specialists without creating commingling problems. Merriam-Webster defines commingling as combining funds into a common fund or stock. Proceeds from a sale have been commingled with other funds. So I sell a stock. I'm an advisor, financial advisor. I sell some stock, and I commingle funds from your sale of stock with my sale of stock. Well, that would be a big no-no in the financial world, wouldn't it? Let's look at another definition. Combining things into one body. It's most often relative to funds and assets. When a fiduciary, a person entrusted with management of funds, other than his or her own, as a biller, and we don't take possession of any money as billing companies, but we have fiduciary responsibility to our clients because we manage that billing. We're managing those funds. So, entrusted with the management of funds other than his or her own, mixes trust money with that of others, the fiduciary is commingling funds and breaching his or her fiduciary duty. A member of a corporation's board of directors commingles funds when he or she mixes personal funds with the funds of the corporation, and an attorney who commingles his or her money with money belonging to a client, the major violation of ethical standards, right? So that is a more precise legalistic definition of commingling. Let's take a look at how Medicare feels about it. Remember, what is our encounter rate? It is our total allowable cost divided by our total number of patient visits. And productivity, payment limits, and other factors are considered in this calculation. So it's important to remember when we're talking about commingling, what is our rate? Well, our rate is representative of our patient cost, and our patient cost is a function of our total allowable cost and our total patient visits. We know these things from other sections of our rural health clinic billing series. The AIR is set via the cost report. Provider-based clinics file their cost report as part of their hospital or parent entity. Cost must be appropriately allocated and tracked for RHC space and personnel. Really, provider FTEs need to be measured via formal time study, and we're measuring their time in the clinic available to see patients. Our medical director, physician, PA, nurse practitioner, nursing FTEs have a major impact on our cost reporting. And our lab expenses as non-RHC services must be allocated and reclassified appropriately. Our cost reporting software does the lab expense reallocation kind of automatically. But remember, we're being really careful about how we're tracking costs for rate setting. Commingling in the Medicare Benefit Policy Manual, Section 100, refers to sharing RHC or FQHC space, sharing space, staff, supplies, equipment, or other resources with an on-site Medicare Part B or Medicaid fee-for-service practice operated by the same RHC, FQHC physicians or non-physician practitioners. So it's saying RHC space mixed with another Part B or Medicaid fee-service provider. So now this is, I'm reading this because it's direct quote out of the Chapter 13, Medicare Benefit Policy Manual. RHCs, FQHCs must maintain and provide adequate cost data based on financial and statistical records that can be verified by auditors. Sounds pretty specific. We must identify and remove from allowable costs on the Medicare cost report all costs associated with the provision of non-RHC FQHC services such as equipment, supplies, facility overhead, and personnel. So we already are in that habit for our straight non-rural health clinic services. We can furnish other services outside the scope of our RHC and FQHC benefit, such as our lab, technical component diagnostic services. As long as we're authorized to furnish these services and they're covered under a separate Medicare benefit category. Look, it doesn't say the services can be billed separately. It says the services must be billed separately, not by the RHC or FQHC, which means not by our RHC or FQHC provider number, but under the appropriate A or B MAC using those payment rules. So what are our non-RHC services? Our non-RHC services are hospital services. Our providers are outside the rural health clinic. Those are by definition non-RHC services. Our lab, diagnostic testing, those are by RHC statute non-RHC services. We must carve those out and remove those non-RHC allowable costs from the cost report, including space, equipment. Again, I've already read that. These are our list of non-RHC services. Medicare excluded services, technical components, lab, DME, look at that, telehealth distance site services, group services are non-RHC, ambulance, prosthetic, body braces, services at certain other Medicare facilities, i.e. your hospital, and hospice services. So these non-rural health clinic services can be provided during rural health clinic hours, and it's not a commingling function. And you know why it's not a commingling issue? Is because it's by statute how we must do it. Hospital services, physician services at the hospital, must be billed to the MAC fee-for-service. If we're a CAW and we've opted for option 2 billing, our outpatient services are billed under the parent MAC, and our physician services at the hospital are reclassified out of the RHC costs on the cost report, and this is not commingling. On the option 2 billing, that outpatient services does not affect your rural health clinic claim. It affects the cause outpatient claim. It's not a rural health clinic claim. But regardless, hospital services are defined non-RHC services and can be billed during non-RHC hours, and it's not. Duplicate Medicare or Medicaid reimbursement is also commingling. And look at the parentheses here. Duplicate Medicare or Medicaid reimbursement includes situations where the RHC is unable to distinguish actual costs from those that are reimbursed on a fee-for-service basis. So remember about our cost accounting methods, and the MAC has the ability to determine if they're correct. If we have no method to distinguish actual costs from our fee-for-service, if we're just doing it, oh yeah, we're just have non-rural health clinic hours and we're just kind of doing that. Well, selectively choosing a higher or lower reimbursement rate and not being able to adequately account for your costs are both considered commingling, financial triage. We're getting into really difficult territory here. What constitutes duplicate Medicare reimbursement? Billing a rural health clinic service to Medicare Part B, physician fee schedule, fee for service, $1,500. Billing venipuncture. Remember, venipuncture is part of our encounter. Billing injections. Remember, we went through that list. That's why we went through the list. These are defined RHC services. That's what goes on our UB04. And if we're billing defined RHC services during RHC hours separately and to the Medicare physician fee schedule during rural health clinic hours, we are commingling. Period. Making decisions based on how the service is paid in a particular setting, delivering that service, i.e. what we just saw before, selectively choosing a higher or lower reimbursement rate based on the setting, is duplicate reimbursement, is financial triage, is commingling. Unbundling RHC professional services. We're going to talk about a treatment area here momentarily. That is duplicate Medicare reimbursement. It is commingling. It is a fraudulent bill. Venipuncture, as defined, as stated in the Medicare Benefit Policy Manual, Chapter 13, is part of our RHC encounter. We cannot carve that out and bill it to Medicare Part B fee-for-service. So if we're billing venipuncture fee-for-service, we're commingling. So expressly, MLN 8504, venipuncture is included in the all-inclusive rate when furnishing an RHC by the RHC practitioner. And you know what? If we want to get into tricky language about, well, we have a leased person in our rural health clinic, and we can have these distinction between who's a practitioner or who's not. Medicare is not going to read. Medicare does not do creative reading. So CMS, it says it's included in the all-inclusive rate, period. Leave it that way and you won't have any risk of commingling. That's what we're here to avoid, right? RHC hours. If an RHC or FQHC provider furnishes an RHC service, remember, servant supplies, incident 2, physician service, servant supplies, incident 2, nurse practitioner service, servant supplies, incident 2. If we have a defined RHC service rendered during RHC hours in the RHC, we've got to bill it RHC, FQHC. We can't bill it fee for service. It's got to be billed as an encounter, period. It's a defined RHC service during RHC hours, case closed. There is explicit reference to treatment areas, treatment rooms, procedure rooms in the Medicare Benefit Policy Manual, Chapter 13, Section 100 on commingling, where this language was not in the Medicare Benefit Policy Manual in years past. These interpretations evolve, and what may have been once allowed is no longer. The Medicare Benefit Policy Manual, the last several years, each update has contained this language to prohibit RHC's billing for outside professional services to Medicare Part B from an area outside or adjacent to the RHC. So we cannot have a treatment room in our RHC that we're carving out and we're creating a white line and saying that treatment room over there is non-RHC space and we're going to go over there and treat this patient and take this lesion off. We can't do that. Treatment space in the RHC, any services rendered during RHC hours have to be billed RHC. We cannot financially triage that patient and take them across the white line. The across the white line just needs to be rural health clinic space. We can't have a treatment room. The procedures done in our rural health clinic during rural health clinic hours are billed rural health, period. We can't have an island of non-RHC professional services within our RHC space. RHC treatment space and patient care areas cannot be shared with non-RHC providers during RHC hours, even for non-RHC providers from the same organization. This is not to be confused with having non-RHC services such as lab and x-ray, but defined RHC services must be billed as RHC during RHC hours. It's that simple. Services furnished at times other than the RHC or FQHC posted hours of operations may not be billed to Medicare Part B if these services for that provider, if the provider's compensation is included in the cost report. So that's commingling. So if we're including that provider salary in our cost report to support our rate, we cannot also bill that same service fee for service. That's duplicate reimbursement. So no islands or treatment centers in our RHC anymore, no longer allowed. We cannot have an RHC provider on our cost report billing fee for service at the time. So physician, provider at the hospital. We have to carve out hospital time for our providers if they're at the hospital seeing patients. That time cannot be included in our cost report. As I mentioned, we can't take defined RHC services and split them out and bill them fee for service. That's a really important concern. Non-RHC services are not physician and incident 2 services, are not NP and incident 2 services, are not preventive service encounters. So we can't reasonably split an RHC service out to bill it non-RHC. It's just contrary to our advice. You may establish non-RHC hours and provide professional services that will not be billed as RHC, but we have to post that these are non-RHC hours. The entire RHC has to be non-RHC at the time. So it's not that room, that hallway, that side of the room, that side of the building. It's all or nothing. The whole clinic is non-RHC or the whole clinic is RHC. It's not by hall, it's not by exam room. It doesn't work that way. We've got to post our non-RHC hours on the door and notify patients that these are non-RHC hours. They won't know what that means, but we have to post that on our door, and really need to notify your state agency as well as your accreditation organization if you're using one. So if you ask the state, they'll say absolutely. You have to notify them of non-RHC hours. You can set up non-RHC hours. That's doable. Ask yourself some questions before you do it. What's our objective? Is it because we're trying to get paid better under non-RHC? Of course, that's going to be a consideration, but is that the reason you're doing it? Is the carve out are we carving out so we can bill incident to injections? That doesn't work. A lot of times the question is, well, I'm having specialists in, or I'm doing a lot of procedures. So my procedures I can't do during rural health clinic hours. It's a $350 charge. Well, the issue is we really need to look at what you'd be paid under fee for service. Your charge may be $350, but I'll bet the Medicare payment is below your rate. There's not much that we would do in the rural health clinic, especially if you're in a provider-based uncapped setting. There are not a lot of primary care services that are really going to exceed that rate. There'll be some procedures, but systematically, we generally stay underneath the rate for that reimbursement. So we really have to ask, if you're trying to carve out procedures, the next thing to say is, are you really doing that many of them? A lot of times we think we're doing a ton of procedures. Oh man, I'm doing 10 a week. Well, it's really 10 a month. So we need to ask what we're going to do during non-rural health clinic hours. Maybe we're having group counseling sessions. That would be an appropriate non-RHC to carve out, or an RHC thing to carve out. Maybe you do want to do procedures. We have a lot of procedures that we do, and it's too much of a disruption in our daily schedule. So we're going to set up Wednesday afternoons for procedures, and Wednesday afternoons the entire rural health clinic is a non-rural health clinic, and everything that happens on Wednesday afternoons is fee for service. Now keep in mind, we've just taken 1/10 of our rate out of the cost report calculation. We're going to carve out one afternoon, so we are reducing our all-inclusive rate by doing that. So we really need to proceed cautiously when we're trying to establish non-rural health clinic hours, and ask a lot of questions about why, what's our actual volume, what's the objective, and is it financial triage. Payer contracts. I put a slide in about occupational health, and really occupational health is and can be considered a rural health clinic service. When you read rural health clinic service, it's taking medical history, making medical assessment, medical decision making, et cetera, et cetera. These are rural health services we're providing. So a lot of times we get fearful that if we have a special payer contract with a local employer or a specialty payer, that's somehow commingling. These are not commingling. These are really just like other payer contracts. So you're contracting, a local employer is contracting with your RHC to provide care to their employees on a specific fee schedule during RHC hours. Great. It's not commingling. There's no reason to set up a big non-RHC or some other service for those employees. It's a payer contract. Same with drug testing services. Same with DOT physical. Special other payer contracts. Now we get into particularly ticklish areas where maybe we're wanting to do some holistic or some non-FDA approved or aromatherapy or things like that. Well, I will reserve my personal opinion on those. But those cash treatments like that would not really be considered RHC services would not have those during my rural health clinic hours. I think those are easily distinguishable from what we're talking about with these payer contracts with local employers and drug testing and that type of those types of activities. So payer contracts are fine. I would not be afraid of payer contracts in the context of commingling whatsoever. Let's talk about how we would use space. So that's often the biggest issue. Now here's the issue in this particular example. We had a weight loss clinic I'm going to go north, south, east, west on this, even though I don't think that quite aligns. Our weight loss clinic is over there, non-RHC on the west side of the clinic. We have a pharmacy and non-RHC on the east side of the clinic, and the center of the building is rural health clinic, including our lab, file room, exam rooms, offices. Now, as you can see over there in that central hallway going really from east to west, traditionally prior to this location becoming a rural health clinic, the patients would use the central waiting room and cross rural health clinic space to get to the weight loss clinic, even though if you can see on that very western end there's an exit sign. There's a separate entrance and waiting room for the weight loss clinic. Well, here's the deal. Non-RHC patients cannot have access to RHC patient care areas. So we had to close the hallway and we installed a door. The pharmacy was already sequestered. The non-RHC spaces looked like separate practices. The weight loss patients had to be redirected to the other door to check in at the appropriate place. We could not continue crossing rural health clinic space and checking weight loss clinic patients in the RHC waiting room. So we built an interior door where that file room is and over by the pharmacy to prevent access to the RHC from those areas during RHC hours. Let's talk about waiting rooms and reception areas. We can share waiting rooms and reception areas. Certainly there would be infection control considerations, and there would be HIPAA considerations. If we're having cardiology share a waiting room with our RHC, how are we keeping our sick RHC patients away from our cardiology patients? So regardless, we can share waiting rooms, telephones, receptionists, check-in, check-out areas with another entity, but we must maintain accurate records to ensure that all costs put on the Medicare cost report or for the RHC only, and we're reallocating the rest of that out. So if we have a shared waiting room, how would we do that? There are any number of mechanisms that our accountants can come up to allocate space for a shared waiting room and reception area. We could talk about services, we could talk about square footage, we could talk about staff, we can talk about a lot of different allocation methods to do that. We can share space, we just have to make sure we're keeping clean records and we have a sound and documented allocation methodology. That's the really important piece. We have a sound allocation methodology that we can prove with documentation. If the RHC is located in the same building with another entity, such as an unaffiliated medical practice, x-ray and lab facility, dental clinic, emergency room, RHC space must be clearly defined. If the RHC or FQHC leases space to another entity, all of those costs associated with the lease space must be carved out. So if we have outside providers, we have to make sure those spaces are clearly defined, and we're not just talking here by signage. We're talking by square feet, we're talking by cost report allocation, clearly defined. Very important. As such, if we're having visiting specialists in our RHC, what are some of the ways that we can deal with that? The best way is just have the specialist bill as part of the RHC. Specialty services work very well as long as we maintain 51% primary care as measured by total provider hours, 51% primary care, we can have all the specialists we want to in our rural health clinic, and they can bill as rural health clinic providers. No carve out, we don't have to sequester services, easy peasy. If we have somebody renting space, they bring their own staff, they do their own billing, we're carving out that space, we're allocating overhead out of the cost report, we've got to put up signage that those outside providers are not some of our providers, but they're visiting. We can't just have specialists coming into our rural health clinic and leasing space without some kind of signage on that. We can't do it. So the appropriate way to structure a specialty clinic and an RHC in the same space really is fairly strict. The RHC, we're sharing waiting room, reception areas with our specialty providers, even if they're from the same organization. Our patient treatment areas have to be totally separate from one another. We cannot have patient treatment areas that share space with a specialty non-RHC provider. We can't have it. That is commingling. I would rather that each clinic have their own patient registration and check-in, check-out personnel indicated by signage. That way we have less of a cost allocation and tracking to make. The clinics must function as separate practices other than their shared waiting room and reception space. We have accurately tracked costs and an allocation method documented. That's the only way to do it. Here's a good example, and the floor plan is hard to read, but the colors give us the indication that we need. So again, going north, south, east, and west, the main waiting area for this particular space is up in the north central region between the green Suite 100 Rural Health Clinic and the yellow West 102 non-RHC. So everyone shares that waiting room, and then we have our behavioral health folks down in the southwest corner of the building, and you can see the white hallway that goes around that northwest corner, around the green RHC space. That's where patients walk from the waiting room to the non-RHC space. So no shared space. All of the doorways between all of these spaces are closed. We share a waiting room. We have an easy cost allocation method here, and once the patients are called, they go to the correct area of their clinic. So this is how we would have to do an RHC and specialty clinic in the same four walls. They've got to look like different practices if they're not going to be billed as RHC. At the end of the commingling section in Medicare Benefit Policy Manual, it says that the AB has the MAC, has the authority to determine acceptable accounting methods for cost allocation. So here's what CMS is saying. The MAC has all power in this. There's basically no arguing with the MAC. If they say it's an acceptable accounting method for allocating these costs, then it's appropriate, and if they say it's not, then it's not. And look at this, in italics. In some situations, the practitioner's employment agreement will provide a useful tool. So we got to be sure that our employment agreements are keeping our RHC and our non-RHC straight. And if we're being compensated out of the RHC, we're not billing those services fee for service. So commingling is a scary topic, but it's a very serious topic because we can't mess with it. You'll get some major sanctions, and your rural health clinic license and probably your hospital license would be jeopardized by violating these commingling requirements. So nothing to take lightly. We have some draft guidance on co-located space. This guidance has been put on hold. This guidance has not been implemented because of the public health emergency. So it does, however, give us an insight into CMS thinking on what they were about to enact for the public health emergency took effect. We can be co-located with other hospitals or other healthcare entities in co-located space. This is actually relative to provider-based space. We can be located on the same campus or in the same building. We can be co-located in its entirety, or certain parts of the hospital can be co-located. Outpatient departments of one hospital are located on the same campus or in the same building as another, or located next to a Medicare certified. Look at that, we get an RHC or FQHC right there in the guidance. So we're talking about co-location of rural health clinics in hospital provider-based space, and the fact that it has to be maintained separately was the point of all this. It's expected the hospital have defined and distinct spaces of operation for which it controls at all times. So that includes designated patient care areas, infection control, protection of patients, and HIPAA violations. So Medicare is looking at these shared spaces in terms of HIPAA violations and infection control, and in terms of public versus non-public paths of travel. So perhaps we have a public path of travel through our rural health clinic, and of course, that's not going to work. Both entities would have to be individually responsible for their own. This includes our public and non-public paths of travel. So we have considerations for public spaces and paths of travel, including public lobbies, waiting rooms, reception areas, etc. So again, this last guidance was not implemented, but is provided as an insight into CMS space sharing thinking. So again, let's summarize. Commingling. You cannot share space. You cannot share patient care space between an RHC and a Medicare Part B provider. You can set up rural health hours versus non-rural health clinic hours and provide services during non-rural health clinic hours, but it's the whole rural health clinic or none of the rural health clinic. It's not part of the rural health clinic. It can't be just those 3 exam rooms or that procedure room. Those are not adequate carve-outs anymore. So RHC hours and non-RHC hours, all or nothing, period. The best thing to do, integrate those specialists into the RHC, advertise specialty services, and then anything that needs to be out of the RHC goes to hospital outpatient or hospital inpatient, of course. Keep the services appropriate for the rural health clinic in the rural health clinic, and anything that needs to go should go. And then we don't have all of these commingling considerations in the first place. And just remember, these concerns evolve. The Medicare Benefit Policy Manual has changed significantly over the past 5 years. And over the past 10 years, I would say this is probably one of the biggest changes, is they've really tightened all of the commingling rules and restrictions. So they're just really nothing to take lightly or not take deadly seriously. So now let's talk about Medicaid and a couple of different Medicaid agencies.